Did you find any issues with the notes yesterday?
Hmm?
Did you find any problem with the notes?
No. It was actually a pretty busy day.
Yeah.
Yeah, well, that's the thing. You gotta adjust it so it's not yeah, so.
Actually, Wendy got me a new mic. Yeah, it's not a fancy one like yours.
I'm gonna do the ride to Vancouver in August. Seattle to Vancouver. RSVP they call. Ride to Seattle to Vancouver and party. That's what the P stands for.
Has McBride come back yet?
I don't know.
I heard 4 to 6 weeks.
Is that right? But he probably, it's the nuisance come all the way down here, of course, and that he's walking.
I had to
with
speak
his
to one of
crutches,
his
you know.
partners about a patient who was leaving the Everett Clinic and came to me and told me he was going to be out for at least a month.
Is that right? Oh. Just when I can go skiing with him up at Whistler, now he gets hurt. I got an Epic pass. You know what that is? That includes Whistler on it. So. It's for next year, though.
Does it have out-of-state areas in it too?
Yeah, it has all over the Western United States. Actually, there's a place in Japan.
Oh, really?
And you have places in Europe you can ski on it, too. I don't know that it's how many
It's called-
people are going to
it's called-
use it.
Save very much money.
It's called Epic?
What's that?
You're not going to save a lot of money by having.
No, that's true. And the other thing is, it isn't cheap if you have it for the multiple areas. It's $900.
The red cones.
Yeah,
But-
I know.
But I mean, I always I thought like the same. But when I walk
And I
by,
have to get it
they're
6
only
or 8
walking
times in.
the white
I
aisle.
couldn't help.
Well,
so I
that's
just
the
didn't
major
put there.
thing on it. It's
Yeah.
got all the veil areas.
Because there was no one
Breckenridge,
else there,
'cause I got
so I
places to
figured-
stay.
Yeah, people are afraid, but it's
Yeah.
not.
That's
They
why I got it,
literally
'cause
just
it's
like
veil.
mark the cone outside.
Breckenridge,
It's-
Beaver Creek.
Well, I
It's
still
got Telluride on
find
it.
fun.
I
Anywhere
don't
else
know.
was unbelievable.
Get over there. It doesn't have
I
any
drove
of the
around for like
Aspen
20 minutes.
places. Have you skied Aspen?
No, it's very.
I haven't been to Aspen in a long time.
Oh,
Are
yeah.
you how's your
To,
vacation?
what's the
How
other
about you? How was your CIS meeting?
big mountain?
That's a Valley Aspen.
Yeah. There's Buttermilk
Yeah.
and
Aspen Highlands, Snowmass.
Oh,
Snowmass, yeah.
I was there a couple of years ago. That's
Oh, I think it's real nice over there. It's just a hard place to get to. That's why I haven't, you know, when the American Academy meeting was there in Denver that one year,
I know.
that's the time I went over there. I went over to ski there.
Can you get there straight from Denver, or do you have to go all the way down?
You have to go all the way through Glenwood Springs and come back. So it's
Hey, how
like
are
a
you?
4-hour drive, or
We're busy
3.5.
over
You really want
Not too bad.
Yeah.
busy?
I
So what we did just for fun, my brother-in-law lives, had a place in Frankfurt. We skied 10 resorts in 3 days.
No, they walk.
Because on the
I don't know,
Aspen
they
one, there are
read
4
on
ski
There's
areas
all
on one
They
ticket.
don't have the final path. They
This
want
is
us
the
to look
Same
at
thing
the
for
path
Vail,
and
there are
see
3
if
on
there are
that
any
ticket,
treatment
Beaver Creek,
options.
a little
'Cause
place
you
called
wrote in your
Arrowhead.
last
I don't know
note,
if you ever heard of it. It's kind
when
of
you get
dependent
path
on
results,
Beaver
call
Creek.
us back.
And then, of
and
course,
we
the
will look at the
Breckenridge
report
has
and
3 on
But
that
the
because
path
it's got
results
a basin and.
was back late. Was back by the time.
I think we hear it.
From
So
Michigan.
there, you could ski 10.
Oh, I
sent
never
it to
said. I
Michigan.
never
Keystone.
wrote this in
They
Michigan.
sent it to Michigan though for.
They said
like,
I went to that
for a
meeting at
read.
Keystone
Anyways,
once, you know, National
so-
Jewish puts it on.
Yeah, so
But
it's,
I told them to call us back when they have the actual
Mild.
report.
it's not very
They're
exciting.
well, the only thing is there are
So
usually
we have a
more
new skid.
professors than
I
there
never-
are
Right.
people that come to the
What?
meeting. But I guess you get one-on-one attention there, and you know they have
It's
the
all
meetings
because
from
of you,
6:30,
How
7
did
in
you
the
bring
morning
all
till
of them?
9:30,
You're the
then you can
magnet
ski.
for skid.
And they re-meet.
Yeah,
There's
every
more
time
skid.
she's on call, she gets us a skid, baby.
But again, I haven't done that in 20 years.
You want me to go like draw a chart?
It's
When
good.
every time we have a diagnosis of skid, I mean, Jay has the data. And we can plot who's
Well, I'm
attracting the
impressed you're
skid
still
baby.
skiing.
attracted.
That would be
Beating most people, although again,
Some me.
you go to
How's your flight back there?
It
some of
was
these
good.
resorts,
Oh no, it got
especially Sun
delayed.
Valley, you'll feel
Why?
young.
Weather?
Yeah.
I
It
don't
is,
know.
it's
They
amazing.
played
Sun Valley
from
has more
somewhere else,
skiers
and
than they play.
it was
But they're in
late.
shape.
Yeah, they,
Yeah,
If you got
it was
a little
like-
luck
yeah,
and
we got in
and
the
they
stay physically
Huh?
active, you can ski
You
in
arrived
your
really
80s.
late.
like at 11.
in my
Or like
when I was
10:30.
in college, and we would ski at
But
night.
Troy dropped me home.
It was this couple.
Oh yeah,
skiing
right.
Yeah.
all
That's
That's
so
so
nice.
sweet of her. Oh my god.
He drove you.
Yeah, I was like,
He leave his car at the airport.
Parker.
no, his wife and son.
It looked the same.
Oh.
except
Yeah, so I met them.
Husband and wife.
But
How
he
old is
Clearly
that?
were in their mid-80s.
like-
Now they don't.
That was a rarity back
in
then.
school.
Remember, a lot of resorts, if you were over 60, you got a discount.
I know.
Most places don't give you any discounts anymore. So.
Stevens does, you know.
I know, Steven said,
15
that's
bucks.
true. Hey, at 62, they had a discount. At 62.
That's, geez. Somebody does that.
I know.
You're not old till you're 75.
No, actually, Copper Mountain has a discount. It's $99 for over 65, but that's one of the rare ones. But again, the tickets being $150 now, it's crazy.
You're getting discounted tickets if you're getting it for
Oh, 99 is good.
I don't know how far that's gonna spread.
Busy day
Vail
today.
and Beaver Creek. The basic ticket is to, you can get discounted off that and buy them early. Packages with three days.
Yeah.
I didn't ski there this year. Is it that high? Did you say 300?
His iPads.
Well, again, it's on this path, so I won't have to worry about it. We usually do ski Vail at least one day.
Fun day.
The problem with Vail is it takes you so long to get to the nice places to ski.
Yeah,
You have to worry about getting out of that.
Literally anywhere you think.
true. You stay there a bunch of times.
Yeah, that's why I
We stopped.
It's way close.
Spend,
no, I walk.
well,
Oh,
you can enjoy skiing pretty much anywhere, but you don't really want to be in the face of the thing.
You can run it.
I'd like to be in a couple of those.
yeah. I'll get here at like.
Can't you walk from
Kind of bowls or something.
I sometimes walk.
But it takes you so long to make the
No, I don't walk here, but sometimes I
transitions
do.
from one chair
You just
to
that's
another.
a contradiction.
Your way
I know.
Sometimes I walk. I don't
Like
walk.
sometimes,
before.
not all the
Yeah.
time.
In the
But
afternoon.
sometimes you walk.
Like sometimes when you drive me,
Finding your exit.
Yeah, no, that's true. It's a huge area, but it does allow the most skiers on the mountain to pick any place in the United States.
when I don't drive, then
Yeah.
I'll walk. I wake up early and I walk.
But Beaver Creek's got good slopes and packed in.
It's only 13.
You know what, I've only skied this once.
13?
I always like Vail, I don't go to
Oh, yeah, like, you must be walking really
More
fast.
because
It takes
No, I
me
can't
15
jump.
not
I
as
can't
big.
jump.
It
I
takes
just
me
walk.
15
much
minutes.
It's fine. It's just we sit so far from
fairly short period of time.
basically
You don't live like in the center of the, this area is quite one of the bottom.
So every,
I live right next to the research building.
Yeah, so this is far. This is like the
Not
opposite
that
side of
far.
the dump.
Spent 5 minutes in a line.
Not that
I agree. There's one thing about high-speed quads and sixers. You know, it looks like you do fine, but they can move that pretty well. And it's usually just at the bottom is the only problems like that. There's still some of the old chairs. So, for example, Breckenridge, one of the best areas on the mountain, it's up on the top. And steep is one of the old-fashioned, slow, two-man chairs. And there's still T-bars there. There's still some T-bars. To get at the very top, you know, top of the big ball. Although Breckenridge has the highest lift, I think, in the United States, it goes up to 13,000.
And where we ensure they have to acclimatize.
Yeah.
And everybody's skiing up there.
I always have
there might
sickness
be
for the
a
first
bit
day or two, but it's usually at night trying to sleep. I was chain stoke. I just, you wake up in the middle, and then, you know, and Wendy will say, you don't breathe for about a half a minute, you know, go back and forth between the chain stoke. No, just alcohol.
I don't think it's called
What's that?
I think that's the prep.
I don't think that is either. No, I don't, because I usually, it's only at night. I ski okay. You know, I'm maybe I'm real fast, but it's the nighttime. And then after 2 days, I'm done.
Okay, maybe we could just start
Are you a skier at all?
Huh?
Are you? I was going to say with your job, I thought maybe they wouldn't let you ski.
Is it a patient?
Oh, that's a good point.
You know, it's like athletes in high school.
Yeah.
During the season, they don't want you to breaking your leg or anything.
Well, yeah, I know, Whistler.
I haven't been up Whistler in 15 years, but I had a place to stay. A friend of mine had a house there after he sold it. I've been up there since.
Yeah, my sister had a place up there for a while too, in Green Lake. This was before my data that I had.
Oh, is that? Mm-hmm. Yeah, that, it makes it more convenient if you stay there. Yeah.
That's a good learning.
I can't believe it.
Hopefully she'd be at the top of the list.
How long is the timing? You saw what happened.
I know, but she keeps saying touchdown. What about something like this?
I never really did official. I think like there's a. I don't know what the number.
Are all the timelines?
Everyone live.
No, I didn't have the same.
Everyone has to go to.
Yeah.
So they only go to like right like how do they know?
I guess the one
Yeah,
direct.
Oh, you mean, oh.
Yeah.
Great. I thought you were talking about this weekend. I went out to Power Wash for 14 hours. Good though.
I don't know, and I don't know. I haven't stored
Yeah,
it.
just about kind of date.
These stories.
Usually, I'm not sure it ever sounds. It's an internist.
all right, hang on a second, let me get a little coffee. First announcement is for the year-end party. It's on the 22nd at 6:30. But we've had to make a change in location because of some university policy. So it's not going to be at the restaurant. It's going to be here in this building. We can use these rooms for the graduation and other events, and we can use all the public space. It'll still be catered, not a sit-down meal, but food. I've asked a number of colleagues, one in this room, who I'm not sure responded to me yet or not, to donate wine and beer, but I'm sure he will, Gary.
You need to get Cliff to come. Remember, he brought Leonetti that one time.
Yeah, I can ask him. He's a hard guy to shake loose.
You get just my home wine here. Do
We'll
they
take
allow
what we
home
can
wine?
get. We're not fussy. You make pretty good home wine. So the 22nd, we'll send out an email, and so to speak, is to have sort of skin in the game, so that everybody who says they're going to come does come. We just ask for a donation of $25. For fellows, it'll be free. And I'll just send out an email how you can give that $25, a check, or just send it in a credit card to the University of Washington Foundation, so I don't pocket the money. So for everybody listening outside, put that on your calendar, and everybody in our extended community is welcome.
Tuesday the 22nd.
Next week, Graham
and
and
Len,
I
just to tell them, parking will be available free underneath this building.
free. That's another bonus of this. Parking will be available for free under this building. So there shouldn't be much of a hassle in that regard. Dave's topic today is diagnosis and management of FPIES. I remember when I first heard about this a couple of years ago, because this didn't exist certainly when I trained, and even up to a couple of years ago, it always reminded me of a joke from Seinfeld where George Costanza's mother is asked if she wants a glass of Merlot, and she says, "Merlot, I haven't heard of it. Is it something new you just invented?" So, is this something new you just invented at FPIES?
All right. So let's get started. No relevant disclosures. This is an outline of what we'll be covering. We'll go over a survey of providers about FPIES, clinical vignette, some introduction to FPIES. Then we'll briefly talk about epidemiology and pathogenesis, food triggers and clinical features. We'll go over another clinical vignette, some more clinical features. Looks like a long list, but we'll go relatively quickly, I think. Diagnosis, initial management, natural history, and how to follow up a patient with FPIES, and then a summary and final thoughts. So first, the survey. So this was a survey put out back in 2013 or 14. It was recently published, looking at a few thousand pediatricians and asking about their understanding about FPIES. And only 10% reported a full understanding of FPIES. So there's clearly a knowledge gap here. And 57% limited understanding of FPIES, and about a third never heard of FPIES at all. As far as managing FPIES, about 30% reported managing it themselves, over 30% referred out to a gastroenterologist, and under 30%, about 28%, referred to an allergist. So based on that, pediatricians and primary care providers probably have a limited knowledge of the manifestations and management of FPIES, and I think there's a need for us to go in the community and really educate our primary care colleagues about FPIES and how it presents and how not to miss it. Back 10 years ago when I started, a lot of parents would often find out about FPIES from the internet and then come to see you because this was something that they thought their child had, and a lot of times they were right. And I think it's getting better over time. I've seen parents see their pediatricians who now know kind of what it is. But I think the knowledge gap has improved over the years, but often parents find out about this through the internet and then they end up seeking care. What about allergists? You think that we would be better about knowing about FPIES, and we are, but still a good third of respondents reported poor familiarity with FPIES. And this was a 23-question survey sent out to all Quad AI members in 2014, and about 80% reported managing more than one patient with FPIES, and the same percentage of approximately correctly identified in FPIES clinical video. But even then, there was quite a bit of variation when they asked about dietary management, testing in these patients. There was a lot of variation between allergists.
I would bet that those percentages are high. If only 470 responded, the other 4,000 probably know much less, chose not
Possibly.
to respond because they don't know what FPIES is.
Possibly. Yeah, I don't know. Good question. I don't know how. I don't know how the survey was presented, but yeah, you're right. And so there was clearly some sort of need for standardization and guidelines. So around the same time, international guidelines came out in 2017, which I think has been very helpful, even for me. I've seen FPIES before throughout fellowship, but it's one of those things where it's nice to have, some standardization at least, even though there's a lot of there's paucity of evidence, I think, for a lot of these things. And we'll go over this. These guidelines will kind of come up intermittently throughout the talk. As far as underdiagnosis and misdiagnosis, I mean, FPIES didn't even have its own diagnostic code until recently, and it's often misdiagnosed as viral gastroenteritis or sepsis, often delaying the diagnosis. So let's go over a clinical vignette for a kind of common scenario that we see. This is baby A, otherwise healthy infant, doing very well, exclusively breastfed. And at 4 months of age, the parents decided to start solids, and they did. And so what's often recommended generally has been introducing things like rice cereal, which the baby tolerated. And a week later, or several days later, had some apple, which was fine. And then another week later, had some more rice cereal in larger amounts and some apples. And then about 2 hours later, had recurrent vomiting over a 45-minute period, and ended up looking okay after that. Was not looking well during the vomiting, of course. But about an hour after the vomiting stopped, the infant appeared well, began nursing, and then ended up having some loose stools several hours later. While the child was vomiting, the parents called their on-call provider, and the nurse who answered the call said, look, if the vomiting stopped and the child's feeding now, we'll see the PCP the next day, which they did, and the child was subsequently diagnosed with viral gastroenteritis and had been doing relatively well after the visit to the pediatrician. And a few days later, the parents tried rice again, and then 2 hours later developed recurrent emesis. At this time, it wasn't looking as well, so the parents ended up taking him to the emergency department, where the child was treated with IV fluids. He was actually given epinephrine without improvement, was given IV fluids and admitted for sepsis workup, which was negative, and this patient was eventually determined to have FPIES. Surprise. So a brief introduction to FPIES. As many of us know, it's a non-IgE mediated process where you get vomiting, at least in the acute form, and it usually presents in infancy. So there's two forms. There's an acute and chronic form. The acute form is typically this repetitive, profuse vomiting 1 to 4 hours after ingestion. You can often have diarrhea along with it hours later, and in severe cases can lead to dehydration, possibly shock. There is a chronic form which is less well described, and we'll talk about these differences a little bit later. But these patients can have more chronic symptoms such as occasional vomiting, more chronic diarrhea, and eventually weight loss and failure to thrive, usually in younger infants. So this is a table from the 2017 guidelines. We won't go over every single detail here, but it really does help distinguish between mild to moderate FPIES and severe acute FPIES. And this is actually specifically looking at acute FPIES. And so when it's mild to moderate, I think this is what I would see more often in practice. I think that there certainly have been severe cases. I think, based on my experience, of course, I would see this less often as a presentation, or when parents describe it. A lot of times parents will say that they treated the patient at home and the patient was fine, but there can clearly be severe cases. So primarily affects infants, most commonly caused by cow's milk or soy, although other foods can be triggers, which we'll discuss. And there are some characteristics that can overlap with other non-IgE mediated GI disorders. And if you look at if you look at the column here on the right, lower right, that's where the infant GI disorders would be categorized. This is, again, non-IgE mediated. And the diagnosis is it's just clinical, largely. An improvement of symptoms following withdrawal of the trigger food. Sometimes we do oral food challenges in these patients. We'll discuss some scenarios where oral food challenges would be necessary, and the treatment is essentially eliminating the food. So when we're talking about non-IgE mediated GI disorders, in addition to FPIES, you can see what's called food protein-induced bronchitis or proctocolitis, which pediatricians often see. We actually don't see this very often because the pediatricians manage this, and this is in the middle column. This is relatively very common. It's in otherwise healthy infants who are breastfed and usually caused by cow's milk or soy in the mother's diet, and can occur with formula itself, but often it's from the mother's diet, and it goes away once the mother avoids cow's milk and soy. This usually resolves by 12 months of age. There's typically no vomiting. You can have some mucus in the stool, some streaky blood in the stool, but otherwise these kids are relatively healthy. In the right column, there's something called food protein-induced enteropathy, which should be considered, and it could potentially present similarly to chronic FPIES, where these patients get malabsorption, failure to thrive, diarrhea, vomiting, and these patients are usually formula-fed. Cow's milk formula is thought to be a common cause, but other foods can do this, and it can also occur status post gastroenteritis. It's relatively more rare, and symptoms usually go away by the time when we remove the causative food. And if you did biopsy these patients, villus atrophy is sometimes seen, and this is the sort of kid that a gastroenterologist should be involved in their care as well. And FPIES is on the column on the left, which we'll talk about again in more detail. So as far as epidemiology and pathogenesis, we really don't have a lot of data at all, to be honest. There might be slightly seen more in males. FPIES among siblings has been rarely reported, and the data that we do have is from Israel, although they reported 0.34% of their population-based cohort of over 13,000 patients, but it was kind of higher than expected because the incidence of IgE-mediated milk allergy in that same cohort was 0.5%. So interesting, but again, it's just from one location, so we don't really have a lot of data on epidemiology. As discussed, and we'll keep going over this, it's non-IgE mediated, but in some cases, you can have IgE present, and we'll talk about the significance of that. If you did skin testing on these patients or a blood test on these patients for IgE, it's usually going to be negative. But I still will skin test just to the suspected trigger food to establish that it's negative. And we'll talk about why later. As far as pathophysiology, we really don't know. There's a lot we don't know about FPIES. And one initial thought was, could there be intestinal mucosal IgE that could facilitate antigen reuptake and then eventually cause local intestinal inflammation? Could there be, thought that this is a T-cell mediated process as well, so could ingestion of the food allergen trigger some sort of T-cell mediated inflammation, eventually causing increased intestinal permeability and fluid shift? These are all questions. So there's, as far as intestinal permeability, old study with just a few patients back in 1989 showed intestinal absorption being normal. And for what it's worth, in 2004, a group talked about decreases in food-specific IgG4 for whatever it's worth, and increases in serum food-specific IgA. Now, look, if you have FPIES and you're avoiding a food, I would suspect that your IgG4 to that food would be negative or low. So I guess that's not a surprise to me. The last study here in 2014 listed, discussed casein-specific IgG4 and casein-specific IgA, which were significantly decreased in patients with milk-induced FPIES. And this was, I believe, from Mount Sinai. It was about 30 patients. One thing that I didn't write in here, which I should have, was that they looked at T cells hours after oral food challenges in these patients, and they found that T cell mediated TGF beta responses to casein were significantly reduced in those patients. Now, admittedly, it's been 10 years since fellowship, and my basic immunology and knowledge of immunologic pathways has deteriorated slowly year to year. So I had to look up the significance of TGF-beta, at least in the gut, and we'll talk about that in this next slide. Hopefully we can see this. So, oh, there it is. The mouse. Try to use the mouse. So if you look on this diagram here, this is looking at this page. This was a population of about 28 FPIES patients. They did duodenal biopsies in these patients. These are all FPIES patients with villus atrophy and without villus atrophy, and then control subjects. There was a very clear inverse relationship. They looked at TGF-beta. They did immunohistochemical staining on these biopsies and found that TGF-beta receptor expression was inversely correlated with the amount of villus atrophy. So very low in patients who had villus atrophy, a little bit better in patients without, and then control subjects did a lot better with more expression of TGF-beta. So what's the deal with TGF-beta? At least in the gut, it's thought to be anti-inflammatory and protective for the mucosal barrier of the gut. And when they looked at TNF-alpha in the same population, they found that if you had FPIES and villus atrophy, you had a lot more TNF-alpha found, and when compared to controls, it was essentially negative. So this imbalance of TNF-alpha and TGF-beta receptor expression was interesting. And the last slide, I should go back, that Constantinow study that found the TGF-beta responses to casein being decreased, that their suggestion was maybe TGF-beta, at least in the circulation, could be used as a biomarker for maybe predicting whether patients with FPIES will react to a certain food. So these are all questions and interesting questions at that. Kind of a busy slide here, but this study looked at about 14 patients with FPIES, 16 patients who outgrew FPIES, and healthy controls. And after food challenges, they looked at the blood and found that the innate immune system was really involved. So it activated monocytes, neutrophils, and K cells, and eosinophils versus those who outgrew FPIES. And when they looked at food allergen-specific T cells in the peripheral blood, they were actually within normal range, and this surprised the investigators. They thought T cells would be clearly involved because they thought it was a T cell-mediated process. But they looked at T cells in circulation. They didn't look at T cells in the tissues, which would be interesting. But they felt like, at least in this study, that the innate immune system and systemic innate immune activation was really responsible for the inflammation in that small study population.
Although the last point is curious, since it's immunologically specific,
Exactly.
and the innate immune system you wouldn't expect to be immunologically specific.
Right, and so that didn't, but even though, exactly, the innate immune system was the cause for the inflammation, but didn't explain the specificity that you see in FPIES, exactly. So if you guys have fallen asleep...
Did they characterize those T cells? Were they Th2 or what was that? Because they talk about food allergen-specific T cells.
Yeah, I have to look at the article. I have to look at the article and see before I misspeak about it. Yeah, good question. So if you have fallen asleep, this is what you've missed so far. Pediatricians have a limited knowledge of FPIES. As allergists, there is a lot of variability, I think, between the way we manage it. FPIES is non-IgE mediated. There's both an acute and chronic form. We don't know a lot about epidemiology and pathophysiology. Some interesting studies, but we really don't know so far. Food triggers and clinical features. The most common food triggers are cow's milk and soy. And behind that is solid foods, and namely grains, rice and oat. And the majority of children have FPIES to a single food. But up to 10% of children can have reactions to more than 3 foods. This is a chart from the Mount Sinai's group looking at the most common food triggers. And milk and soy, as you see, and rice and oat. And then it kind of drops off, although we see this a lot. We see a lot of this in different patients, just not as common.
I find rice interesting because in the old days of adult food allergy in a different era, rice was always thought to be so hypoallergenic that this recommended diet for people who you didn't know what was wrong with them was rice, lamb, and water.
Ooh, rice, lamb, and water.
Remember those old days that was sort of the least allergenic diet you could eat?
Yeah, I remember the bananas, rice, apples, and what was it?
Well, mine's the adult diet. Yours is the kids' diet.
So rice is, look, a lot of these things are things that infants see early on, right? And so there's got to be something in the gut that's predisposing them to these foods that are introduced early on in infancy. And this is a very busy slide. We're not going to go over every detail, but it kind of gives you a list of, we talked about milk and soy, grains, meats, poultry, etc. You see all these things in FPIES, but it's important to keep in mind that if you're allergic to one of these foods in a food group, you're probably more likely to be allergic to these other ones. So when we see a patient in practice who has, let's say, chicken FPIES, and they want to introduce turkey, I probably hold off on introducing turkey, at least within the first year, because they could potentially react. So when it comes to rice, I think an important thing to take home with that is that these patients are typically present more severely, and they're more likely to end up in the emergency department for whatever it's worth. And if you have rice FPIES or other grain FPIES, you're about a 50% risk of FPIES to other grains. However, wheat is a relatively safe grain to introduce in these patients. I have a couple patients with egg FPIES. It doesn't happen that often, at least in Australia, it's 11%, Philly, 11%, and again, these are small patient populations in general. What about nursing? The likelihood of having an acute FPIES reaction after maternal ingestion of a food and having FPIES through the mom's breast milk is very unlikely. So that's actually good to keep in mind. There's only been a handful of cases reported. And as far as goat's milk, it has been reported in an Italian study. So milk and soy FPIES and solid food FPIES are two different things. So first we'll talk about milk and soy FPIES. Usually early in infancy, that's when formula is usually introduced earlier on. In extreme cases, it can come on very early in the first few days of life. And obviously delayed introduction of cow's milk or soy in breastfed infants could result in later onset. When it comes to solid food FPIES, it usually comes on later, but obviously that's when solids are introduced at around 4 to 6 months of age, or 7 months in some cases. And if you have an infant who's developing clinical symptoms of FPIES early on with lots of solid foods, the likelihood of them having multiple foods involved in causing their FPIES, it tends to be higher. So what about solid food FPIES in adults? This has been reported. We do often see this. I don't know if you guys have any in your practice. I have a couple of adults who, when they eat shellfish, 2 or 3 hours later, they don't have any other signs or symptoms of anaphylaxis. They just vomit. And they vomit and they get diarrhea, and their skin tests and blood tests are completely negative. And so this has been reported with patients with shellfish, fish, or egg FPIES, and it's kind of an FPIES-like sort of syndrome. And our own Jamie Rosenthal presented a poster at the Quad AI this spring of a patient that I ended up sending to Matt Altman because I was too chicken to do the challenge myself. This was a patient with suspected cashew FPIES. And I don't want to pick on Jamie, but I let you know ahead of time that I wanted you to talk about the case. So go ahead.
So it's a 68-year-old guy who had tolerated cashews, I think, for his whole life. And then about a year and a half before he presented, he said that he started to, I think he had 3 or 4 episodes of after he ate cashews, about an hour later, developed vomiting, abdominal pain, diarrhea. And actually, I think he ended up in the hospital once with hypotension and AKI related to one of those episodes. So he had food challenge at UW, and a few hours after, I think he had a total of like 6.5 cashews over a few hours, he developed severe abdominal pain, diarrhea, and became hypotensive, and actually ended up going to the ED and then getting admitted overnight, and he ended up having, I think, bloody stools as well overnight after he got admitted.
So impressive reaction that he had, and he, he had 3 of these episodes, I think, leading up when I saw him, and then before I sent him to Matt, because he said he wanted to know for sure. He used to eat cashews. Really nice guy, and I said, look, I'm not going to challenge you in my clinic. You need to go to an adult hospital, and which he did, and it was confirmed. And I actually just had him avoid cashew and pistachio just to be safe. I don't think he's clinically reacted to pistachio that we're aware of, but we know that there's a high cross-reactivity between the two.
You know, this is a very good reminder for me personally, and I think internists see people, I just can't remember specifics, but people who come in, you skin test them, they're negative, and you don't think about this. At least I don't think about it, and they leave confused. You haven't answered the question.
Get that story a lot.
Discounting.
Shellfish.
Huh?
Get that story a lot with shellfish.
Shellfish.
Yes.
Yeah.
Episodes of ill gastroenteritis kind of illnesses and their skin testing.
You just write it off as we don't know what it is.
Bad fish.
Yes.
Yeah, you can certainly write it off as bad fish or bad shellfish. But if it happens a few times and it's 2 hours later, profuse vomiting, diarrhea, you wonder if there's a food protein enterocolitis going on. But yeah, a lot of times I've seen patients where you just write it off. Yeah, it just went to a bad place.
I don't think most of them get as sick as this man did.
No,
with
he
hypotension
really
and
got
need
sick.
for admission.
Absolutely. So this was an acute FPIES case, I think, in an adult. In infants, you can see
It looked like that patient had eosinophilia. So
During the episode.
during that.
did you track it later? Did it go back normal? Or?
I don't remember if that was ever rechecked.
Is that relevant for the infants?
What's that?
Is that relevant to the infants?
infants
Bodies
get
that have the
eosinophils.
You can see that in the acute phase in some cases. Yeah. The question is, you'd expect it to go. I didn't check his blood after the challenge, and Matt didn't see. I don't think we did. I don't think Matt did either, so we don't know. Actually, for in this case, whether his EOs reduced. And from what I gather, he does have respiratory symptoms, but he's not he was a very atopic guy, if I recall.
So what do you see on biopsy? Like if you biopsy those people?
We'll talk about it a little bit. You can see various things, but we'll talk about it. Yeah. So in infants, you can see two phases, chronic or acute. And so you can have acute on chronic episodes. So let's say you have an infant who's 5 months of age, introducing formula, can have chronic GI symptoms like diarrhea, intermittent vomiting, and then when you avoid that food, symptoms can improve, but reintroduce it, then you have an acute FPIES presentation where you have vomiting, let's say 2 or more hours after ingestion. You're more likely to have a chronic presentation with formula, like cow's milk or soy-based formula, and then solid food, you can have both acute or chronic presentation, depending on how frequently you ingest that food. This is a little table kind of talking about the clinical features of chronic versus acute FPIES. And as I mentioned earlier, chronic FPIES is really, I think, not very well defined. Patients who present this way, if they haven't seen gastroenterology, they need to. I usually send them to GI to make sure that they determine whether a biopsy is necessary. There's a lot of other things to rule out. There's other non-IgE mediated gastrointestinal diseases to rule out. In the acute phase, patients, keep in mind, patients are really well in between episodes. Even that adult that we saw, he's doing great. Just when he eats cashews, he has problems. And so there's 1 to a handful of foods that can cause these sort of acute reactions. But in the chronic form, these patients are much more, have symptoms on a more regular basis. And it's often a diagnosis of exclusion. We won't go over every detail of this. This is just kind of highlighting the 2017 guidelines, looking at acute FPIES versus chronic FPIES and some of the criteria. And it's kind of nice to see this written down on paper, where they actually lay out certain characteristics to help diagnose either of these forms. Second clinical vignette, let's talk about this one. So this is a 6-week-old boy, former full-term infant, was doing relatively well, breastfeeding, and then mother decided to supplement with cow's milk-based formula while she was nursing. After introducing cow's milk-based formula, in addition to nursing, develops some vomiting, wasn't gaining as much weight over about a month, and subsequently, due to these symptoms, stopped the cow's milk-based formula and just went back to exclusive breastfeeding, was doing relatively well at that point, but reintroduced it at 10 weeks, and then about 2 hours after that feeding, developed an acute FPIES event, which was recurrent protracted vomiting with lethargy. And the word lethargy in the world of pediatrics is never a good thing. and they ended up going to the emergency room where full sepsis workup was done. The patient ended up doing well and was sent home when the cultures were negative. And had been doing well until about 7 months of age, when they were introducing more solids, inadvertently was given some infant jar food that contained milk in the ingredient list, and again had an acute FPIES event. At this point, the child didn't have a large amount of that food, but luckily, ended up doing relatively well after a few episodes of vomiting. And by the time EMS arrived, he appeared well. So that's kind of a example of an acute unchronic FPIES event. Let's briefly talk about some more clinical features. We talked about that in up to 25% of patients, for some reason, we see IgE present. So I think, at least in clinical practice, when I see a patient who has clinical symptoms consistent with FPIES, just to that food, or that food or foods in question that cause the reaction, will just establish that IgE is negative. I think it's important to do that. And I think it kind of sets, it has implications, which we'll talk about, as far as the natural history of the process of these patients' symptoms. These patients typically have a more protracted course and potential for developing symptoms of IgE-mediated allergy to that food, actually. And so when Mount Sinai published some data in 2014, they described that their FPIES patients, at least 39% of patients had FPIES, with FPIES had IgE sensitization to another food, not the trigger food. But when it came to the trigger food, 24% had positive specific IgE. Now, this is Mount Sinai, which is a huge food allergy center, and they have a lot of atopic patients, so the data could be potentially skewed. There's not a lot of data from other institutions, but that's why we say up to 25% can have positive IgE. I think if you look at other institutions, it's a little bit lower. When it comes to milk FPIES itself, if patients have a positive skin test to milk, about 40% change from a FPIES phenotype to an IgE-mediated phenotype over time. In other words, if they have protracted vomiting 2 hours after ingestion, a subset of those kids, let's say a few years down the road, can now develop symptoms of itching and hives, so more of symptoms of IgE-mediated allergy. So another reason to consider skin testing in these patients. And interestingly enough, even though it's technically a non-IgE-mediated process, a percentage of these patients do have atopic disease, such as atopic derm, allergic rhinitis, and asthma. And there is a family history of atopy, as well as a family history of food allergy in some of these patients.
So
yeah,
that subgroup that has the IgE early, have they looked at tryptase in the ER, or?
I haven't seen anything with tryptase.
And are they more likely to have eosinophilia than the non-IgE?
And I haven't seen that documented. Yeah, looking at all the patients to see if their eosinophil levels at baseline are elevated. I didn't run across that. Yeah. As far as labs go, you can see various labs. None of these things are pathognomonic or diagnostic, to be honest. So just so you know, if you're a patient with FPIES, you don't have to get a bunch of labs or radiographic findings or X-rays. And radiographic findings are relatively non-specific, to be honest. So you see a variety of things when it comes to chronic versus acute FPIES. You usually don't get labs in these patients. Obviously, if you see a patient with chronic FPIES, I think it would be prudent to get labs. But by that point, they're going to be seeing a gastroenterologist, or their pediatrician has obtained labs to rule out other etiologies. If you see a relatively well infant, let's say with acute FPIES, and is doing well in your office, there's no need to get lab results at that time, at this point, unless you're thinking about something else. What about patch testing? So if you think it's non-IgE mediated, what's the benefit of patch testing? And so Matt Fogg, who was a fellow ahead of me at CHOP, 3 years ahead of me at CHOP, did a study looking at just under 20 infants and found that patch testing, at least in those few patients, was actually very helpful. And if you had a negative patch test, they didn't subsequently react to a food challenge to that food. But if they had a positive patch test, they did, although there was some clinically relevant results where you'd have a positive patch test and not react in a food challenge. But subsequent studies really found that, at least a retrospective short review of over 400 patients found that this wasn't very helpful. And so patch testing was something that I remember us doing at Chopin during fellowship. I was there from 2005 to 2008, and I've done it in practice a couple times early on when I started here, but I haven't done it since. So there is really no role that we're aware of patch testing in these patients. A diagnosis is really based on clinical history, and you remove the suspected food and exclude other etiologies, and that's really about it. We usually, like I said, don't obtain labs, but if you have an acute event, you could get labs just to establish, elevated white blood cell counts, hemoglobin level for what it's worth in some cases. And we talked about this. So as far as biopsies, there's, based on what I've talked about, but what I've read, there's a lot of non-specific symptoms. I think you can sometimes see villus atrophy in some of these patients. I think more so probably in the chronic form. But there's not, from what I've read, not a specific set of findings that you commonly see in patients with FPIES. And I think it depends whether they have chronic or acute FPIES. But I think it's important to consider biopsy in some of these patients if the clinical history is not cut and dry. And we talked about how there's often a delay in diagnosis with these patients just because of the non-specific symptoms sometimes, lack of definitive diagnostic tests. And a lot of these patients, particularly 10 years ago, 10, 20 years ago, when people didn't know much about this, these patients underwent a lot of unnecessary and sometimes risky therapeutic interventions. And it's just like Len described, the perception of rice being a non-allergenic food, as well as things like oats, could, this perception that these foods are relatively benign kind of delays the diagnosis in some of these cases where, if you hear a kid vomiting after rice, it's kind of, it was kind of confusing to think of rice as a cause of such severe symptoms. So when to do an oral food challenge, I think it really depends. And in all honesty, I haven't done a lot of oral food challenges to FPIES, largely because of my experience with FPIES challenges, in the sense that they can be severe. And so I work primarily in an outpatient clinic. And we'll talk about what the requirements are to do an oral food challenge, but typically it's recommended to do in a hospital setting in general. But you could consider doing an oral food challenge when there's unclear history, the specific trigger food wasn't really identified. Perhaps if the patient's having persistent symptoms despite removing that trigger food, and you want to make sure that you expand their diet, or you could determine whether a trigger food has been outgrown. And we'll talk about when these kids can potentially outgrow it and when oral food challenges can be potentially considered. Now, we're not going to go over every single detail of this protocol, but this was cut and pasted from Up to Date, and that's from protocol suggested by Anna Nowak and colleagues from that article. But you want to have IV access, and you want to have IV fluids available. You want to observe these patients for a longer period of time. Knowing whether they're IgE positive makes a big difference here, right? Because if they're skin test positive and they're one of those, let's say, up to 25% who are skin test positive, it's going to change the way you approach this oral challenge in the sense that you're going to look for more immediate symptoms as well. But if it's classic FPIES, these patients generally need to be in an inpatient setting. But I think when you look at the data, though, which is the next slide, there's a chance that maybe we're being too cautious. How often do we need IV fluids in these patients? And so this was a study relatively recently in 2017 that looked at about 39 or 40, almost 40 oral food challenges, and the majority of them were of equal or lesser severity than historical reactions. And only about 8% required an IV, which was either IV fluids and or steroids that were administered. And the patients who had severe symptoms were all of younger age and with a history of severe FPIES. And so, if you did an oral food challenge relatively earlier, in other words, it'd been, let's say, within a year of their last FPIES event, these patients were more likely to react. The most common symptoms that they found in this study were just vomiting and diarrhea, and usually resolved with minimal treatment. and the reactions didn't usually worsen over time. So it's based on this small study, they would argue that it's reasonable to consider a few factors such as the age of the patient and the length of time from the last reaction. So if you've, let's say for example, have a child who's reacted at 6 to 9 months of age and they come to your office at 3 to 5 years of age, it might be very reasonable to do a very conservative oral food challenge in your outpatient clinic. Although, again, I've done the worst reactions in fellowship that I've seen were from FPIES reactions, and this was done in a hospital setting. In clinical practice, the few that I've done, the last one that I did actually was like 8 years ago, and it was to a patient who had egg FPIES, and was the only reason we did it is because that the mom had said, look, this child has tolerated egg before a couple times, at least in baked goods or in noodles, and we ended up doing just a baked egg challenge just to be conservative, and watched the child for 2 to 3 hours, and on their way out in the parking lot, the child started vomiting. And ended up doing okay, but after the 3rd episode of vomiting, I just called EMS just for backup, and the child ended up doing fine and went to the hospital for observation. So I think I've gotten a little bit more chicken in doing outpatient-based oral food challenges.
Is that number of 39, is that just of 39 who reacted, so there was a greater number who passed their food challenge?
So, no, so this is all, they looked at, this was the patient, I think the N on this was like 20 or 25 or 30. So they did multiple food challenges on each patient. As far, they just looked at all, this was a retrospective review, so they looked at all positive food challenges.
Oh, okay.
Yeah, they just looked at all positive food challenges in that patient population.
And have you guys done a FPIES challenge at the Seattle Children's
so that's a good point. So that's something that we've...
high-risk food?
Yeah, so Frank and Veron and Dan Petroni and I were discussing this a while back, and we really would love to develop some sort of protocol at Children's. And I think there's a need there.
Yeah.
Because you could, in theory, admit a patient, but there's just kind of, as you know, it's hard to get them on the general peds service, and I haven't actually pushed for that to be done. But it'd be nice to have a protocol set in place to do that, because the observation period would need to be a lot longer.
Yeah.
And so it sounds like a good fellow project. but it's something that I think we need to do. And actually, I think Frank is the one who's been in most recent discussions about that.
David, a question about chronic FPIES. Is it just continuing, not recognizing the syndrome and continuing to feed the food, and instead of having explosive acute events, just promoting chronic disease?
Yeah, I mean, that's essentially what it
That's
is.
what it is?
What defines chronic FPIES from other non-IgE GI disorders is the fact that if you avoid the food, it gets better, and then reintroduce it. In a lot of cases, you'll get an acute FPIES event, like that case that we talked about. So that's one of the defining features of chronic FPIES. But then again, the question is, have I seen it a lot? Not a lot. Not that I've seen. And maybe a lot of these kids end up seeing gastroenterology, and maybe we don't see them, and maybe that's why. But in practice, I haven't seen a lot of chronic.
That raises the question, how many patients have you seen? How many in the community? Or do we just not recognize this or not have enough knowledge? I think most of us as internists must miss it, because we see kids as part of our practice, even though we're trained as internists. And I know my problem is I don't think about this because I was never trained about it.
Right.
How many do you have?
I mean, I have to look. I mean, I'm probably under 20 or 30.
Really?
Yeah, up to 20 or 30. But it's one of those things where I think the only reason is because I was involved with the FPIES Foundation, and then they list your name as a potential provider who sees patients, and then so the parents will seek you out for that reason.
Anybody else in the room diagnose this or have patients with it?
I don't see it. I don't see kids under 5. So, there aren't that many over 5 unless it's a mild seafood allergy, and we'll just say they're intolerant of it, and that's the end of that. You don't really need to work them up any further for FPIES.
The outcome's the same.
They just go eat it and they do fine.
Yeah, true. And it really,
that's the treatment anyway.
Yeah, the treatment is just avoiding it. You're absolutely right. And then it really comes down to, doing a quick skin test, in my opinion, just to make sure that it's negative. And then eventually they just avoid it. And the question is, when do you challenge these patients? Invariably, though, I think I would say at least 25%, maybe 50% of the patients that I see will accidentally eat that food at home. in small amounts, mainly milk. They'll sip someone else's sippy cup, and the parent calls you and says, look, they're fine. They just had, an ounce of milk and they're fine. So I'll actually confirm that with the parent and then be very conservative and say, look, start at a teaspoon, and I'll let them do it at home and increase by a teaspoon a day until they're actually having like a half a cup of milk. And so a lot of times these patients will ingest the food at home without any sort of reaction. And so we'll talk about this, but just a differential diagnosis slide. There's another CliffsNotes summary. So if you've fallen asleep, these are the most common food triggers: cow's milk and soy, and protein, we talked about. Older children and adults can have FPIES, but it's rare. We talked about acute FPIES and chronic FPIES, and a subset can actually have atypical FPIES where you have positive IgE to the trigger food. These patients can have increased atopy for whatever reason. There are no laboratory or radiographic findings specific to FPIES. Oral food challenges can be done, generally recommended in the hospital setting, I think, depending on the age of the patient, depending on the clinical history. And I would definitely consider a gastroenterology consult, particularly with patients who have symptoms of chronic FPIES. Initial management, we just talked about, avoiding the food. That's essentially what it is. If you have a child with cow's milk or soy FPIES from formula, it's absolutely fine to breastfeed. And in very rare cases where a child reacts to the mother's breast milk, then the mother should completely eliminate the trigger food from her diet. But generally speaking, we don't have, at least in these cases, have the mother avoid milk or soy in their diet, because usually the child does well with it. You can try hypoallergenic formulas. And when it comes to milk, if someone has an issue with cow's milk, knowing that this is kind of some similarity with the cow's milk-induced milk soy protein intolerance that we talked about earlier, the proctocolitis that was in that middle column, if you guys remember, there is some co-reactivity between milk and soy. And so, at least in FPIES, if you have a child with cow's milk FPIES, you would probably want to introduce soy down the road. If you did introduce soy down the road, you need to introduce it with some sort of supervision, I believe, because you could react to that as well. And as far as chronic symptoms, you usually improve within about a week or so of switching to a casein hydroxylate-based formula. So as far as initial management, the whole rationale here is that infants with cow's milk or soy FPIES are at increased risk of solid food FPIES, particularly rice and oats. So we usually don't introduce them early on. The recommendations are fruits and vegetables at 4 to 6 months of age instead of cereal. Continue breastfeeding, and if an infant tolerates a variety of foods early on, you can start kind of liberalizing things. Now, the whole point of this, number one, is that a lot of this stuff is not set in stone. And if you look at the evidence for these recommendations, it's relatively weak, to be honest with you. And a lot of these things really depends on the child and the presentation. A lot of these parents, and rightfully so, they're worried. They see their kid having a significant reaction at 5 months of age. They're scared to introduce anything. So this is where the allergist can come in and helping guide their diet, or at least providing them some information. And just to be there and nod and show that you actually know what FPIES is very reassuring to them, to be honest. And have seen some patients with this. It's helpful because up till seeing the allergist, in most cases, they get a lot of blank stares. And so I think we talked about that knowledge gap, and it is real in these patients seek care. So at least by 12 months of age, you can start being more liberal, perhaps waiting to give rice and oat or poultry until 12 months of age. However, if you have a kid who's eating rice at 7 months of age and they're doing fine with it, obviously just keep giving it to them. There's no reason to avoid it at that point if they're clinically doing well. But if the child's never had some of these foods like rice or poultry, you might want to wait until 12 months of age. And if you do have a high-risk food, which we'll talk about what that is, introduce them individually probably every 4 or more days. And at 12 months, again, as far as cow's milk or soy, you can start giving cow's milk or soy then if there's no prior history of a reaction to those foods. And again, we mentioned this before, if you're tolerating a food in a food group, such as legumes, if they're tolerating, let's say, green peas and soy, the likelihood of them tolerating other legumes is going to be relatively higher, so it's fine to introduce those incrementally. And again, a lot of this data is based on single-center experience, mainly Mount Sinai, so it really depends on the patient. As far as high-risk foods, low-risk foods, this is actually a very helpful table that I actually give to parents after their first visit, and it kind of gives them some guidelines as far as what to introduce early on, at 4 to 6 months of age, 8 months of age, 12 months of age, and it gives them some sort of things to start with that are less likely to react to. This is just a table, just for reference. It talks about common food co-allergens in kids with FPIES. And this is something that we typically don't get involved in, right? In finding good food substitutes. This is when the dietitian really comes in handy. And we really need to make sure that if you're avoiding, especially more than one food group, I think it's very important to have a registered dietitian involved, especially when they're avoiding, let's say, a bunch of grains or cow's milk. You want to make sure that you have alternative sources. So I make sure that a lot of these kids seek care with a dietitian. What about baked goods? We know that in IgE-mediated allergy, that baked goods are often tolerated, particularly when it comes to milk and egg. But in FPIES, that's actually not the case, as demonstrated by that anecdote that I gave you of my child who reacted to egg and baked goods with an acute FPIES event. The thought is that T cells will recognize it, even if it's in small quantities. And so the general recommendation of these patients is just to avoid assuming that they haven't had that food yet. Obviously, if a child's eating that food regularly, let's say crackers and cookies with egg in it, for example, and they're tolerating it, continue. But generally speaking, I would avoid those foods.
This idea that this could be T-cell mediated or anything with immunologic specificity doesn't seem to make a lot of sense. If you have milk or soy, and then months later you have it to grain, you're switching food groups dramatically. That doesn't seem to fit with immunologic specificity.
Yeah, there's definitely something missing there. Yeah.
Mechanism gap.
There is, absolutely. On the first visit, one of the things that I give each patient is an emergency treatment letter. This can be actually found online, and the letter looks something like this. It essentially describes what FPIES is, and if you base it on clinical history diagnosis patient with FPIES, you can write the name of the food there. You give that to the parents just so they have it in their wallet or their purse, so that if they ever end up in the emergency room, the treating physician will at least be familiar with it. Obviously, you allow the treating physician to do what they need to do to rule out other causes and treat this patient, but it's important to have them keep this in mind as a diagnosis. I'm going to kind of skim over this as far as the emergency treatment plan. This is mainly for if you're in the emergency room or in the hospital doing a challenge. IV fluids are very important. There is possibly some role for methylpred and other supportive therapy, although not a lot of good data behind this. Epinephrine can be used in patients with shock, but it hasn't really shown to be helpful with other acute FPIES symptoms. As far as Zofran or ondansetron, that actually has been shown to be helpful in the hospital setting and may quicken the resolution of symptoms when given at the onset of acute FPIES. So if a patient who's reacting, Zofran can be helpful. And I think in that patient, that Matt Altman I sent to Matt, I believe they gave Zofran, if I'm not mistaken. I have to go look back at Jamie's history there. This is just, again, we're not going to go over every detail, but for mild, moderate, and severe acute FPIES reactions, these are some guidelines that someone can follow during a reaction. So this is all from the 2017 guidelines, which is something that we really didn't have a lot of information before, and it's been very helpful to have. This is something that can be utilized, and this is a table that I actually give to parents as well, copies of this, so that if a reaction happens at home, they kind of know when to seek care. And so if the general rule is if a child vomits 3 or more times, or more than 3 times, or is looking ill, they should call 911 and have the patient evaluated. But if it's just a couple of episodes of emesis, sometimes these patients do well. I think it's important to keep in mind how much food they ate, what the food was. Has the child had severe reactions in the past? So if you have a kid who's in the emergency room twice and begins to vomit, I probably would call 911 at that moment. And not just wait and see if the patient worsens. Generally speaking, this can be a good guideline.
Do you prescribe any rescue medications to these patients?
I mean, I've done that once or twice, to be honest.
Right.
But it's if a child's vomiting, what are you going to do? Oral Zofran is not going to work. You could use, you could administer it rectally, I would suppose. But I feel uncomfortable about that. If the kid's sick
tell
enough,
them
you need
to
exactly.
call 911.
Exactly. There's been one case where the parent said, look, instead of waiting 2 hours, if I see the patient, my child had this food, can I give them Zofran orally and, go to the ER? And in that one case, I said yes, but, it was one of those things where I don't think I had a good rationale with describing it. Yeah. But it's not routinely done. What about natural history? Usually, it depends on where you look, where the data is from, but usually by 3 years of age, milk and soy FPIES usually resolve. But patients that can have a more protracted course are listed here. So if you have solid food FPIES or atypical FPIES or older age at the initial episode, you can have a more protracted course. And obviously an oral food challenge can be helpful in these cases. And it really depends on where you look in the world, right? So when you look at Mount Sinai's data, 5 years of age based on their data, but this is a very atopic population. If they have detectable milk IgE, because in quite a bit of patients it's actually later on. But it really depends on when you challenge these kids. So Korea, as an example, they're pretty aggressive with oral food challenges, and they documented that in their population, 64% resolved by 10 months of age, soy 92%, because they challenge these kids really early on, obviously in a hospital setting. But I think it's really population-based, and the data is all over the place. That can be very frustrating. As far as solid food FPIES, here's the data, and you can see some variability with different foods. Again, we won't go over every single detail, but it's just interesting to see around 3 to 5 years of age, I think, is a good time to think that that child's possibly growing out of their food allergy. So when you see a patient in clinic for follow-up, and we're wrapping up here closely shortly, I would assess whether there's any new reactions or new trigger foods, assess for signs of atopy, and really expand the diet and the barriers we talked about. There's parental hesitation and understandable fear for introducing foods, and what you don't want is a 9-month-old who's just exclusively breastfeeding and develops oral aversion. That's what you want to avoid. And testing to IgE prior to an oral food challenge, as we discussed, and registered dietitians can be helpful.
David, just on that last point,
sure.
do you know the dietitians know what this disease is? Have they heard of it?
Good question. And I haven't seen any survey of dietitians done.
I mean, are they from your own
but the
experience?
ones, the ones that I usually will send them to Children's,
Okay.
and they'll have seen this before. And these are the folks that work with gastroenterology as well, so they're pretty in tune with it. And then these are some guidelines of when to perform an oral food challenge. I think it depends on what institution you look at as far as when and how often they recommend it. So Mount Sinai, every 18 to 24 months to do a food challenge. In Korea, they recommend it sooner, after 12 months of age for cow's milk and 6 to 8 months for soy, which is pretty aggressive, but it's good because a lot of these patients will not unnecessarily avoid that food. And then some summary and final thoughts. Initial management, as we talked about, eliminate the food. I think it's important to have an emergency treatment plan and a letter for any future episodes. Really, the phenotype and the natural history really depends on various factors. Age of onset, trigger food, IgE or nationality. I think expansion of diet, again, is very important to these patients, and we really need to educate. I think it's our job, to educate primary care providers about FPIES and how to manage it. So that is it, and a good resource for parents are these 2 websites, which can be helpful and can really guide them through this whole process. And that's about it.
We have 2 organizations for rare disease.
For FPIES.
I'm joking.
Oh, exactly right.
Yeah.
I know.
It's like
Yeah.
we have 2 organizations
exactly.
for a rare specialty,
exactly.
the college and the academy.
Go ahead, Jen.
So, say you have a diagnostic clinically in a FPIES to cow's milk at 6 months and they avoid it, would you then feel comfortable doing and the patients avoid it and there's no accidental ingestions? So when they're 3 or 4 or 5, would you do it in your clinic then, or are you still?
Yeah, by 3 to 5 years of age, I think it's reasonable to do. And again, admittedly, I've been relatively chicken just because of my experiences with the food challenges. But albeit those patients that I've seen reactions to were relatively younger. So if Frank were here, Frank Ferrand, he'll actually do some challenges at 3 to 5 years of age, and I'm warming up to the idea. I think when I was looking at the data, looked at that study from 2017, looking at if you have an older kid without had a significantly severe reaction that ended up, where they maybe developed hypertension to something, I think it's important to keep that in mind. If a kid with milk FPIES who ended up in the hospital with significant hypertension, I would still feel weary about doing that. But if it was a mild acute reaction and the child's 3 years after their last reaction, I think it's reasonable to do it an outpatient, very conservative approach. Now, at CHOP we did 2 doses. We did a small dose, and there's per kilo, and then you dose it again 30 minutes later. The question is, why do you dose it in 2 doses? I think the thought is maybe you want to rule out any sort of immediate reaction, I suppose. Watch them for half an hour to 45 minutes and then dose again. But the protocol that Mount Sinai recommends is 3 doses over a 45-minute period. You can look that up. It's also on the slide.
And these patients typically would have an IV in your office, or
not in the outpatient.
Not,
You usually
right?
put them in. Yeah, I would feel more comfortable if we were able to do that. So that's where I think that's our next step. I think is that develop a challenge clinic at Children's, at least for some of these patients, because otherwise they're just avoiding it much longer than they probably should.
Do they change that protocol if these patients have IgE?
Yeah,
as well.
I would, if you have IgE present, I think the protocol would be more of a protocol that we would be used to. But I think it would kind of be a hybrid of the two in a lot of ways. And your observation period will still need to be longer, though, right? Because usually with IgE-mediated allergy, you're going to watch for maybe up to 2 hours after your last dose. These kids are 4 hours, watch 4 hours, even if they have IgE present with a clinical history of an FPIES reaction. Yeah.
That's a good point. So, I mean, these people you're going to keep around for at least a half a day.
Yeah, I mean, that's the whole thing. I mean, if you're going to do it in your outpatient clinic, probably watch them for quite a long time, and probably carries through the rest of the day. So, yeah.
Well, thank you. It's clearly evolving from something that didn't exist at all when us old guys in the room trained to. Let me just remind, so next week we have Param Nair. Remind your friends and colleagues, he's sort of the star of the whole year, in my estimation. Should be giving another brilliant talk about eosinophilic asthma, new therapies for eosinophilic asthma, induced sputum, and just an all-around brilliant guy. Very worthwhile session to attend. And we'll send out a reminder about that as well. So as many as those, not that this wasn't a brilliant talk.
I'm looking forward to next week.
This was the highlight of the year
nicer
today.
Yeah.
This was the highlight.
All right. All right, Dave. Thank you.
Something you can. Well, I was thinking to myself,
Oh yeah. Every week is a highlight. Every week is a highlight.
That'll be good. That'll be good next week.
All right.
he's a heavyweight.
Yeah. All right. And count on you for some wine.
Tuesday.
I don't think anybody, there won't be any editing whether it's home brew or not. Sure, there'll be,
Yeah, I can take that out. In the six.
Exactly.
I need some anti-malarial things.
Well, you know who should
No, I know what I can get. I just want
But just for
I know. I got an email about being exhibitor at I was like, okay, so you're managing partner and you're like vice president. Do you like?
I'm actually not too involved in that.
Oh, you're not?
Well, you know who'll tell you that.
Did it?
Yeah.
2 years ago, right? So then you kind of help. If people ask you questions, then you help.
Okay.
No, he just
I was like, no
stepped
wonder
down from being the chief.
Oh, okay. But I just keep seeing things where I'm like, does he have any time for
The only
himself?
thing is I want somebody to call with a prescription. I feel.
Do you get a vacation this summer?
No,
The other thing is, I'm okay with Jay.
I heard. Congratulations.
But Wes could give you advice.
So if I really want to know,
If you really want,
Around that time. Hopefully, fingers crossed.
Are you doing like a baby move or
research it
anything?
myself.
You might go to.
okay.
Back to
Whistler?
so you're probably a regular here.
But
I can be.
Before you're younger.
Don't
yeah,
Just a
that's
mini,
nice
a mini
there.
baby.
Yeah, it's nice there.
Yeah.
You don't want to fly.
Sweet,
Yeah.
yeah. I know you're really busy during July. I just wanted to gauge interest. We have the opportunity in late June
What's
for
that?
even a Paula speaker.
You know, they used
It's
to
going to be like a national broadcast, like talked all from national July. Would that be the vein? Is that something that you think you'd be interested in? I know you said like July is one of those. Is that?
Yeah, would it be more in person or would it be?
No, I don't.
We used to have
It would be a
big audiences.
broadcast. I don't know that for sure. I just haven't heard any. Is that something you think when I asked people would be interested in?
I think so. I think the way, I think most people would recommend like having a day in a spot and say whoever can come and each one
used to have a lot of
staff.
Yeah.
If that's relevant.
Yeah.
To go to each office, for example,
Yeah.
so having a set date and time.
I got one.
Cool. I don't have
Anybody
anything
want
set. I just want to gauge some interest.
And some people would, you know, and not to say that you should do this, but in an ideal world, you could do something in the Seattle area.
Well, there's some sort of reaction going on in the gut.
But
I think that's why they're doing these broadcasts.
well, that's what I was going to say. Then
And
they could
because if
just go
people
on.
don't want to leave big traffic, I think they can even listen in
I
from
think that's the
home.
limiting factor. It's not funny. I just don't want to go anywhere after like 3 to 7. You just want to chill.
I don't. Yeah.
So that would be, I think that we have to
I'll just keep you updated.
Yeah, crazy.
All right.
No. Yeah, all right.
Congrats
Scary.
again.
Thank
That's
you.
so exciting.
There must be fantastic.
I had mine in August. It's a good time. Good, he's 8 months. He's,
How are you?
good, how are you?
We just avoided each other.
Yeah, for the most
First
part.
3 months.
First 3 months, and then I've been like sheltering him for all the flu and stuff.
That's one thing you sent out in letter.
And you were a ski guy, weren't you? Okay, that's why.
Yeah, do you know if it's a boy or a girl?
That's what perplexes.
You talked about severe.
It's so severe.
Not that I'm aware
Like
of.
pregnancy.
I haven't come across any.
Yeah.
Not that I got that other.
Or we do,
Right.
like,
Yeah.
I think Jared said, we do saying we definitely.
But how many do you not know? I know they get to the lethargic.
Or they get labeled like.
So at least you're doing the right
Yeah, for negative
I haven't seen it.
So there aren't very many adults who show up with this, but you got the American Natural History of that.
A whole lot. I think they.